My name is Rick Garcia. I'm a trainer at the UCLA Integrated Substance Use and Addiction Programs. I'm sure you're familiar with ISAP. You've probably seen a few of my colleagues around. If you're not familiar with ISAP, ISAP is a leading research and training center located at the UCLA David Geffen School of Medicine. We don't have a ton of time, so I'm going to be jumping straight into the material. I hope that's okay. But I'm going to go straight into our learning objectives for today. And it was awesome seeing a lot of these responses in the chat box. All of this sounds really great. I wish going to watch a movie on the beach sounds like a lot of fun right now. I wish I was doing that. I love being here, but I wish I was doing that instead, right? I think we all would. All right, let's get into it. Let's look at our learning objectives for today. So our first learning objective is to define trauma and a trauma-informed approach. Our next learning objective is to increase the awareness of the impact trauma has on health outcomes. This is followed by to increase knowledge on the principles of a trauma-informed care approach. And our last learning objective here on the slide is building skills and using strategies to reduce trauma and highlighting resilience. So our agenda is pretty straightforward. We're going to be defining what trauma is and the impact that trauma has. Next, we're going to talk about what a trauma-informed approach is. We're going to talk about considering organizational change within your own workplace and trauma exposure for providers. So let's get into our first section for today's training, defining trauma and its impact. But before we do that, I'm going to ask our producer here if they could launch a quick poll for us. And this poll question is pretty straightforward. All polls are anonymous, so please answer as truthfully as you can for all the polls that you'll see throughout today's training. But our first poll of today is, I believe trauma impacts most of the clients I work with. So you have A, strongly agree, B, agree, C, difficult to know, D, disagree, or E, strongly disagree. That's you could drop it into the chat box as well. That's perfectly okay. If you're okay not being anonymous, that's okay here as well. So I see A, tons of A's. I don't think I see anything different than A. So strongly agreed. Yeah, I can imagine, right? We're seeing we definitely meet our clients in one of the most vulnerable times in their lives. So it's understandable that you'd be seeing a lot of the impact that trauma has on your clients' lives. I'm seeing tons of A's, so I don't think I need to wait around any longer. So I see strongly agree is the most chosen response. So let's look at what is the definition of trauma that we're going to be using in today's training. So trauma here is defined as individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So you can see it's a pretty broad definition. It's encompassing a lot of areas of life, but trauma has that impact, right? Trauma can have a huge impact on many areas of our life. It's not just, it's not just physical, or it's not just emotional or mental. It can have a lot of effects in how we go about our day-to-day and how we experience life. So let's talk about the 3 E's of trauma. So events and circumstances may include, when we're looking at E, events and circumstances may include the actual or extreme threat of physical or psychological harm. So for example, a natural disaster or experiencing violence, or it can be also severe life-threatening neglect for a child. Maybe they're experiencing life-threatening neglect that imperils their healthy development. And then the next E on here is experience. And so the individual's experience of these events or circumstances will help to determine whether it is or isn't a traumatic event. A particular event may be experienced as traumatic for one individual and not for another. So for example, 2 children could be removed from an abusive home, and one can have a completely different experience where they saw it maybe as the beginning of an exciting period in their life, whereas the other individual sees it as being a really adverse event in their life and actually leads to a lot of problems down the road. So different people are going to have different experiences to the same situation. We all have different lives. We all have different ways of thinking, ways of being. So of course, we're going to have a different way that we're going to experience a traumatic event. And the long-lasting adverse effects of the event are a critical component of trauma. So these adverse events may occur immediately, or they may have a delayed onset as well. And the duration of the effects can be short-term or long-term. In some situations, the individuals may not recognize the connection between their traumatic event and the effects. So some more examples of some adverse effects could include, an inability to cope with normal stressors and the strains of daily living, to trust and benefit from relationships, to build relationships, managing cognitive processes such as your memory, attention, your thinking, regulating behavior, of course, and controlling the expression of emotions. So, traumatic events can have long-lasting effects across a wide range of areas in someone's life. So up here on this slide now, we have four different types of trauma. So we have acute trauma, we have chronic, complex, and vicarious. And let's start at the top up here. We have acute. So this is a single or a short-term event. So this is something like a car accident or maybe an assault or an overdose scare. And these events can have lingering effects later on. They can become triggers for PTSD symptoms, and it could lead to substance use for coping. Next, we have chronic, and this is ongoing, repeated, or prolonged exposure. So this is something like long-term domestic abuse or, repeated abuse as a child at the hands of your parents or a loved one. And so this really works to erode trust. And it helps raise the risk of developing a substance use disorder later in life. Next, we have complex trauma. So this is multiple invasive traumas, often from childhood. So this could be physical abuse as well as emotional neglect, as well as experiencing violence. So it's really common in clients with high adverse childhood experience scores, and it really impacts that individual's relationships, their ability to self-regulate, and it fuels addiction cycles as well. And the last one up here is one that you're all probably very familiar with, and this is vicarious trauma. So this is secondary exposure through working with traumatized individuals, and this affects providers, and it's from the result of the emotional toll from hearing and working with your clients and working with them and dealing with their own traumas. So hearing these repeated abuse narratives can have a very real response in the provider. So some of the symptoms that you can experience are things like burnout or cynicism. It requires a lot of self-care and a lot of supervision to maintain yourself and maintain your well-being. So the brain adapts to protect itself from the stress that trauma produces, and certain parts of the brain are placed on high alert, while other parts become much less active. And this can have a significant impact on a child's ability to control their emotions and their ability to stay calm or pay attention. And makes them more. It could lead to impulsivity and problems in forming healthy relationships. So the pen right here, you can illustrates how trauma can begin when we're born, and it continues to impact our lifespan and our health outcomes. So you can see here, starting at the very bottom, you have generational embodiment historical trauma, leading up to social conditions and local context, adverse childhood experiences, leads to disrupted neurodevelopment, and up we go all the way up to early death. So it has, you can see the ripple effect that trauma has on your experiences and how these traumas can even, precede when you were actually born, right? We all have family traumas or things or most of us, I would say, probably have family traumas and things that have happened, to our parents and to our grandparents, and those things have an effect on us as well because it shapes how they view the world and how they navigate that, how they navigate parenting and how they navigate, most of what they do in in their daily life. So these are just some stats on trauma in the U.S. So you could see up here that trauma prevalence in opioid use disorder, 99.7% of individuals in opioid use disorder treatment report at least one lifetime traumatic event. And then within that group, 41% were 41% of the participants screened positive for PTSD. So it's almost, it's almost one in two, which is pretty high. PTSD and SUD comorbidity in veterans as well among U.S. veterans seeking treatment for substance use disorder, 31.7% meet diagnostic criteria for current PTSD. And with higher rates observed in those with alcohol and opioid use disorders. So again, pretty high, right? That's about one in every three. It's a pretty high comorbidity, and you can see as well, just looking at the general population, adverse childhood experience prevalence in the U.S. population, 63.9% of adults report at least one adverse childhood experience, like abuse or household dysfunction, and 17.3% report four or more, according to 2020 CDC data. So again, really high, right? 17.3%, that's about one in every five have experienced four or more adverse childhood experiences. So pretty high. So we could say most of the population has experienced at least one, or excuse me, 63.9% of the population has experienced at least one adverse childhood experience. So pretty high numbers. And so it really drives home the point of why it's really important for us to have a trauma-informed approach when working with our clients and with our patients. So I want to open up the floor for all of you. I know that we go back to the poll. All of you said that you strongly agree, or everyone that responded said that you strongly agree that trauma shows up in your clients' lives, the clients that you work with. So I want to open this up for all of you. This is an open floor discussion. You can drop it into the chat box, or you can come off and mute as well, and you can just let us know, how does trauma show up in your work? And two, how do people communicate this experience to you? So if you want to place it into the chat box, or you can come off on mute. Either one is okay. So again, our question is, how does trauma show up in your work, and how do people communicate this experience to you? And thank you for putting that in the chat box, Morgan. So I see Colton saying, calling our office incessantly. Do you want to expand on that, Colton, and maybe give a little bit more information on why exactly they're calling your office incessantly? I see Sabra saying chronic pain. Yeah. Christine is saying, I work with victims and offenders of family violence. It comes at bed intake and throughout treatment. Thank you for sharing, Christine. I see Jan saying, assisting the community when Maui wildfires happened and listening to the stories they share. Oh, yeah, yeah. I mean, that's got to be devastating experience, and a very traumatic experience, I can imagine. So I can imagine how that trauma shows up in the work that you do. Jennifer saying, when doing in-person assessments, my members often start to gaze off and stop talking. And I am too on Maui. Yeah, and thank you for sharing, Jennifer. Yeah, I mean, people can have very different reactions to trauma, right? And that is a common experience. People, kind of just getting lost in their thoughts, or kind of just going into a blank space is a common experience. I see Colton saying, needing assurance as a way to cope with their anxiety, to voice concerns, complaints about workflows or negative interaction with a staff member. Got it. Yeah, and we'll talk about that a little bit more later on in this training. How the different ways in which that trauma can show up in people's interactions with other individuals, and we'll look into seeing some ways that maybe we could reframe that and not add to their trauma or not make them feel worse, right? Mary is saying people struggle to use coping skills and engage in coping skills, use community supports. A lot of times this is communicated by challenges with attending appointments, hard time talking about things, often saying I don't know or struggle with eye contact, frequent forgetting. Yeah. And Mary, you're spot on right there, right? Some of the common responses that we see to trauma, struggling with eye contact, frequent forgetting, hard time talking about things. Yeah, certainly that can definitely happen. And Christine saying, I have a member who recognizes this trauma and responds with a knee-jerk reaction. He can be combative when he is frustrated, scared, and anxious. Yeah. I can imagine. Catherine is saying trauma often shows up in my work through behaviors rather than direct disclosure. So youth may withdraw, they may test boundaries or have emotional outbursts, coping mechanisms, and many communicate their experiences indirectly through body language or humor, while others slowly open up as trust builds. Recognizing these cues helps me respond with empathy and create a safe space where they feel supported. I love that, Catherine. Thank you for sharing that. Yeah, recognizing these cues and recognizing that everyone's going to have their own different way of displaying that the the discomfort that trauma brings. Kat is saying can show up as lack of trust in providers. Yeah, of course. And Angela saying poor sleep, depression, non-adherence to diet and treatment regimen. Yeah. So, this is excellent. Thank you everyone for sharing. And yeah, I agree. There's so many ways in which trauma can show up in the work that we do with the clients that we work with. And some of them might be coming from multiple traumatic experiences. And then there's collective traumatic experiences like the fires on Maui as well. So all of those things have a different way of manifesting within each client. And like Christine said, let me scroll up. I don't want to say it was Catherine, excuse me. Like Catherine said, recognizing those cues and being able to pivot and adjust as they come up. It's a really great strategy in building rapport, building trust with your clients. Yeah, I love that. All right. Okay, so let's look at what exactly a trauma-informed approach is. So some of you have already alluded to knowing, what a trauma-informed approach is. If you don't know it, you're already using it. But if you don't know it by its formal name, you're already using it. I can assure you. I've seen some of that in the chat. But we were focusing on the definitions, the types, and the prevalence and all of that. But we're going to focus. We're going to shift into showing how you can use this approach in your work. So what does a trauma-informed approach do? Well, if we're aware that trauma affects has an effect on our clients and the success of our work, how can we be more trauma informed in our approach to working with our clients? Well, first, let's define what we can do. What does a trauma informed approach do? So a program, an organization or system that is trauma informed realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So that's the definition we're going to be using for today for a trauma-informed approach. And according to SAMHSA's document, where we found this definition, that includes the four R's, which are realization, recognition, response, and resisting re-traumatization. And this is really the basis of a trauma-informed approach. So in this next section, we're going to talk a little bit more about what it means to realize, to recognize, and respond, and to resist re-traumatization. So we're going to start with this realization. Again, the assumption is that trauma is a part of the experience of most of the clients, patients, and consumers that you work with. And you need to have an attention and a more concentrated focus on trauma-informed approaches is really necessary to working with this population of clients. And this realization shifts the focus from the lens, shifts your focus from what we see as what we typically see as problems, and we start asking people, instead of asking what's wrong with you, we start asking what happened to you, right? What's the story behind the reason why you feel this way? What's the story behind the reason why you're behaving in this manner? So this slide here is on reframing your thought processes. And so reframing and realization work together in a trauma-informed approach. And they're especially for those working with people who have PTSD or substance use disorders. And so this slide shows how we can shift our perspective to support their healing process. So some examples of this technique are on the slide. So you can see here on the left, we shift from, instead of asking what is wrong with you, we'll shift to asking what has happened to you. And rather than looking at our clients or our patients' behavior as disrespect or defiance, we view it really as their response to trauma. And when they tell us that I won't do this, we can try and interpret this as maybe I can't do this is really how they're feeling. And rather than seeing them as giving you a hard time, we can say that they're having a hard time. And rather than seeing them as manipulative, maybe we can just see that they're just trying really to get their needs met. So this doesn't mean that we condone outright really disrespectful or abusive behavior, but it does mean that we do take a step back and we do our best to try and respond from a place of non-judgment and understanding. So reframing our thought processes will play a really critical role in developing strong rapport with your clients and patients, especially when you learn to master this skill and learn to really interact with your clients from a place of non-judgment. And so we all have a preferred style in how we handle threats to our safety. And it's good to know your own and what happens in your own body and your mind when you perceive or experience a threat. I'm sure you've all seen you've definitely seen fight or flight, right? I'm sure you've probably heard of freeze, and there's also fawn. These are the most common methods by which we handle threats to our safety. And these are really just survival responses to threats. They're driven by the autonomic nervous system, and they don't really follow a set order, as we mentioned, or as you all alluded to in the comments. We all respond in different ways, and the responses will vary by person. It's going to vary by their trauma history and the situation at hand. But let's look at the first one here on the left over here. So we have fight, and this is facing any perceived threat aggressively. So this is, yelling or being really aggressive in tone, using heated speech. And so a client could be arguing with you and could be very argumentative or combative in a group therapy session. And this could be a reflection, this may reflect a trauma-triggered a fight response, excuse me. The next one is flight. And this is avoiding. So this is like skipping sessions or mentally checking out. Like some of you had said some of your clients have done. And so this could be, an example could be a client leaving treatment early. Maybe it happened after a confrontation, so they're probably fleeing a perceived danger. The next one we have on here is freeze, and this is, being unable to move or act against a threat. So this is paralysis, disassociation. This is like a blank stare during intake questions. And this could be a client shutting down when you ask them about their trauma history. And a lot of times this could be misread as non-compliance, but it could just be very well be a response to trauma. And the last one on here is fawn. So this is immediately acting to try to please and to avoid any conflict. So this is really just people pleasing, right? This is overly agreeing with their provider so that they can avoid conflict. And this can really stem from a deep fear of rejection, right? It could be a fear of rejection, a fear of rejection for going against what is maybe they consider to be the direction of travel, right? Or maybe what they see as the direction of travel, they feel like they can't go against it. And responses can overlift and they can shaft and they can shift as well, excuse me. So, it could be freeze and then fawn. And in substance use disorder treatment, misrepresenting these as resistance can also re-traumatize as well. So knowing how to know what how knowing those cues in your client and your patient, like Catherine mentioned, can be really key to making sure that we're not misinterpreting their actions or seeing them through our own lens rather than the way they're actually experiencing it within their own experience, within the context of their own life, excuse me. And so recognizing the signs and symptoms here. So symptoms of trauma or re-traumatization. Recognition is really about understanding some of the general signs and symptoms of trauma and re-traumatization listed here. And this is not a comprehensive list, but it has many of the common ways in which trauma comes through in our behaviors. So you could see here flashbacks and nightmares, anxiousness or fear, difficulty concentrating, trouble sleeping, fatigue, social isolation and avoidance, overall intense negative emotions, an inability to control emotions, and strong physical reactions to triggers. So these are a few of these. I know I saw a few of these mentioned in the chat box earlier, but I'm sure we're all familiar with these. These are some of the more common ones. Again, this isn't an exhaustive list, but these are some of the ones that are very common and key to look out for to make sure that you're not missing those cues in your client and your patient's demeanor. So, in responding to some of the ways in which people communicate or engage due to trauma, there are these three skills here that can be really useful from when you're trying to come from a trauma-informed approach. So, we have empathetic reflection, normalizing, and affirming strength. So, we're going to break these down a little bit further, and we're going to go into empathetic reflection first. So this concept, there are three ways that you can do this. You can reflect the feeling behind what the person is saying. You can use the person's own words to reflect what they're saying, and you can summarize this, or you can summarize the situation of what they're going through. So some examples of this can be saying something like, "You're frustrated with all the rules that you're being asked to follow." So that's reflecting the feeling, letting them know that you're hearing them, you understand what they're saying. You can even reflect that by using their own words. So saying something like, "You don't know who to turn to for help," right? Just reflecting back their own language to them. In essence, you're normalizing it. You're not letting them feel, you're not taking them to a place of shame. Instead, you're maybe taking them to a place of feeling accepted. And the last one here is summarizing their situation, and this can be exemplified by saying something like, "You were not expecting to have to move based on the contract, and you feel like you really need some help." And so this lets them know that you're paying attention, that you're with them, you hear them, you're interested, you want to know more. This is a place where you can freely share. So empathetic reflection is a really great tool to do this. It really helps them feel heard and really validates their experience. So let's look at these in action again. So this is empathetic reflection. So let's say your client was saying, "I keep messing up. I relapsed last week, and now I feel like everyone here thinks I'm a failure. I don't even know why I bother coming back to treatment." So you can empathize with them by saying, what would you say? What would you say if you're trying to use the skill of empathetic reflection? What would you say to your client? You can drop it into the chat box, or you can come off on mute as well. But what would you say? How would you respond to this statement here? So again, if your client said to you, "I keep messing up, I relapsed last week, and now I feel like everyone here thinks I'm a failure. I don't even know why bother coming back to treatment." What would you say to your client? What would you say to your client? Let's see if I can get at least just one response in the chat box. That would be great. Or you can come off on mute as well. So I see a couple responses coming in. Valerie is saying change is really hard. Uh, Rena, I hope I'm not mispronouncing your name, is saying it sounds like this past week has felt discouraging. Yeah. And Beth is saying, first, I would thank them for coming to the spot. Excellent. And I see you're still typing, and I see William is saying, well, relapse can be part of recovery. Um, yeah, definitely. Relapse is definitely a part of recovery. Mary saying, I hear that this feels really hard for you right now, and you've been trying. This must be really difficult to be kind to yourself right now. One day does not define all of your progress. Yeah, I love that. I love that. Yeah, definitely letting them know, it's not the end of the road. It's not the, you can get back up, right? Uh, Beth, the appointment. Thank you for clarifying, Beth. And then I see Renata saying, you're here now, and commitment is the most important part of recovery. Excellent. Yeah. So these are great responses here. And again, another way that you can respond to this, it sounds like you're feeling really discouraged and maybe judged after your relapse, which makes it hard to keep showing up. Again, just reflecting back to them what they're saying, right? Letting them know that we're here, and we hear them. We're interested. We're not gonna judge you. I see Carolyn saying relapse is a part of recovery, and it's admirable that you came back as a commitment to yourself. Yeah, I like that a lot. I like that a lot. Excellent, excellent. So let's look at this next one. So this next one again, we're going to be using the same statement. So this is I keep messing up. I relapsed last week, and now I feel like everyone here thinks I'm a failure. I don't know why I bother coming back to treatment, but this time I want you to normalize it. What's a normalizing statement that you can use? So normalizing, just to give you a little bit of background, normalizing your client's concerns can be really helpful for someone who's experiencing distress. So you want to use statements that feel less alone and make them feel less alone in what they're going through. And you can also affirm that their concerns are valid as well. So sometimes a way that you can typically begin a normalizing statement is by saying something like, Many people I talk to feel very similarly to you." Or, it's common to feel that way. I hear it all the time. So go ahead, um, take a few seconds to craft a normalizing response and drop it into the chat box, and we'll see what you all come up with. All right, let's see. Oh, thank you. Thank you, Morgan, for putting that to the chat box as well. Thank you. All I need is just one. That's all I need is just one. If someone could drop one into the chat box, that would be awesome. So I see, just one second. They're all starting to come in really rather quickly. Here we go. Valerie's saying, most people relapse 7 to 10 times before they can push through. I like that. Yeah, it's normalizing, right? Relapsing can definitely feel discouraging, like you're not moving forward. I can assure you that you're not the only one who has relapsed, and everyone here is not looking down on you. I like that. I like that. No judgment, just letting them matter of factly, hey, it's a normal part of the recovery process, and no one here is judging you. I can assure you, you're not the only one that's gone through it. Yeah, I like that. Renata is saying practicing involves mistakes. We're human. Sometimes we make mistakes, and that's okay. We give ourselves grace, and we reflect on how we can do better next time. Yeah, definitely. I love that you're all using that trauma-informed approach. I see it in a lot of the comments here. Carolyn saying it's natural to feel that we failed when we had a relapse or had a setback. Yeah, it's okay. It's okay to feel that way, right? We're not trying to say, "Oh, no, you shouldn't feel that way," or, "Oh, well, it's better to not think." No, we want to normalize it. We want them to feel, "Hey, it's okay. It happens. It happens. It's a normal part of recovery." And it's okay. We're going to be here for you, and we're not going to judge you. And, we're not judging you in any way. It's a normal part of the process. Yeah, it's normal to feel discouraged after a setback, but coming back to treatment shows your strength. Yeah, I like that. Awesome. Excellent. Excellent. Thank you, everyone. I'm sorry I didn't get through all of them, but I appreciate you all chiming in here. And this is the one that we have up here. So you can normalize this by saying, excuse me, I should have scrolled forward. It's really common to feel like you've let yourself or others down after a relapse, and it's understandable to worry about being judged. Many people in treatment feel this way, and coming back shows a lot of strength. Awesome. So a few of you modeled similar statements in here as well. So I really appreciate that. All right, let's look at this last one here. This is the last one, I promise. All right, so affirming strengths. So again, the statement is I keep messing up. I relapsed last week, and now I feel like everyone here thinks I'm a failure. I don't know why I bothered coming back to treatment. So how can we affirm them? How can we affirm their strengths? What can we say? You've all already done a bit of that. You've done it in some of your other comments, but what other ways can we affirm their strengths? Or what's another way that we can affirm their strength? I like that, Randy, saying keep coming back. Yeah, you want to make sure they're still feeling encouraged, right? Thank you for coming back. It shows your strength. Yeah, you came back. That might not have felt easy, but you did it. I like that, really acknowledging that, hey, it takes a lot of courage, right? Especially when you're feeling the way your client's feeling. They're saying that they're feeling judged. They're saying that they're feeling like they're a failure. They let people down. It takes a lot of courage to still show up and face those people, even though you thought they were looking down on you, right? So it takes a lot of courage to do that. I see Catherine saying you're showing a lot of commitment. You're showing a lot of commitment to your recovery by being here, even when it's really hard. Uh, Mary saying you're so courageous to keep trying and showing up. Your resilience and grit are admirable, and you showed up for yourself today, and that's worth celebrating. Keep going. Yeah, I love these. I love these. And the only thing I want to say about these affirming, when we're using affirmations, we want to make sure that they're relevant. We want to make sure that they're genuine, right? We want to be affirming things that we feel really good about affirming, because if we try to just affirm something and we don't really feel that great about it, it's gonna miss, I would say. Not all the time, but sometimes it's not all, or rather I should say it's not always gonna land, right? So I always like to stick with affirmations that I know, hey, it's gonna roll off my tongue, and it's not gonna sound like I'm faking it at all. I want them to feel like it's a genuine affirmation. So that's the only rule that I would say with affirmations that you really want to be mindful of, making sure that they're genuine affirmations. Not saying that anyone here is not using genuine affirmations, but just a note, I want to put it out there because yeah, affirmations are those that they have to come from a place of a meaningful place within your own heart as well. So here we've an example of affirming the strengths that we came up with is you've shown incredible strength by coming back to treatment even after a tough week. And that kind of determination, despite feeling discouraged, is a powerful step towards your recovery. So for some of you, this might be really easy to land. For me, I might change it up a little bit. But that's a general example of what affirming their strengths looks like. So one thing that we're also doing in working with a trauma-informed approach is making sure that we're highlighting and supporting their resilience. And again, you've all shown that you're capable of doing that with those responses in the chat box. But resiliency, making sure that we're developing their resiliency and their own internal self-worth. That's really what we want to make sure that we're working towards in a trauma-informed approach. So some resiliency-based questions that we could ask. Um, uh, and which will help us to elicit strengths or to hear about coping techniques or the support systems are some of these questions up here. So what do you think helps you bounce back from difficulties? What is the one thing you could do now to have better health and feeling of well-being? How have you faced and overcome the challenges you have had? And how many people around you have helped you overcome those challenges? So you can really see that these questions are really well designed to gather much more information and to really get to understand who your client is and who they are, and how and the challenges that and how the challenges that they have overcome have affected them, and in which ways are they still coping with them. But these are some ways that we can develop resiliency-based questions in order that we could find out what's the best way that we can help our client develop that resilience. We're going to look at their past, at the past struggles that they've overcome and see what worked then. maybe we could apply some of that to the struggles they're facing today, or maybe we can use that as an example to show our client that they are capable of achieving their goals and overcoming struggles and challenges. And another thing we want to make sure that we're doing is we want to resist re-traumatization. So I mentioned earlier about we mentioned a bit earlier about re-traumatization, but we want to make sure that we're defining defining why we want to make sure that we're resisting re-traumatization. So re-traumatization occurs when a person re-experiences a previously traumatic event, either consciously or unconsciously. And this can be caused by stressors that are similar to the environment or circumstances of the original trauma. So something like a smell or a physical space or lighting, imagery, memory, or even a new relationship that can mimic a previously traumatic one. So we want to make sure that we're resisting re-traumatization. Some things are unavoidable, right? If someone has, if someone experienced something at the hands of someone that you just happen to look like, right, through no fault of your own, you might remind them of someone that they don't particularly have a good experience with. Knowing that it's just going back to that reframing process and thinking to ourselves, what could really be behind it? Maybe, maybe the shirt I'm wearing is the shirt that their partner used to wear, or who knows what it is. But it can be re-traumatization can happen from a variety of different experiences and different things in life, and so that's part of what we want to make sure is that we're resisting it to the best way that we can. And what are some ways to resist re-traumatization? So these are some recommendations here. So we can avoid behaviors and language that a client has disclosed as triggering to them, right? And hopefully you've built that rapport with your client. They've shared that with you, or maybe it just naturally came up. But making sure to respect that language, or respect that change in behavior and language that they've essentially asked of you by sharing and disclosing to you that that's a trigger for them. Supporting our clients emotionally if and when they have been triggered. So don't ask them to get over it or to try to continue with the encounter without addressing the trigger. Okay, we want to make sure that they feel like this is a space where they can share that information with us, and that we're going to do our best to make sure that we're not re-traumatizing them. We're not re-traumatizing them. The next one on this list is allowing clients the freedom to leave the room or pause the encounter if they become to feel overwhelmed, which can happen, right? Especially if they're talking about very traumatic events, and if you're in an enclosed space and they start feeling a certain way, that could very well be something that they need to do for themselves and for their own mental well-being. So allowing your clients and your patients that freedom to leave the room or pause for a second is really essential in making sure that we're avoiding re-traumatization. Another thing we could do is being supportive, non-confrontational, and in response to our clients' resistance. So again, reframing our thought processes and thinking, hey, maybe something happened to them in the past, or maybe, like I mentioned earlier, maybe I remind them of someone, or maybe something I said. Right. So being supportive, non-confrontational, don't take it personal. It could be, it could be something else, and it has nothing to do with you. And really trying to keep that mindset is really important in resisting re-traumatization. Another one is believing and affirming your clients when they disclose their traumas. So a lot of times, clients might have disclosed trauma to someone else, and maybe they were belittled, or they were demeaned, or they were called a liar. We don't want to be that person in our clients' lives. We want to take them at their word, and we want to hear them out, and we want to know about past traumas as well, because again, traumas have so many effects and has a wide range of effects in so many areas of our clients and our patients' lives, and in our lives as well, right? So making sure that we're addressing those traumas and that we're aware of what those traumas are can go a long way in resisting re-traumatization. All right. Apply a trauma-informed approach to all your clients without assuming that traumatized clients will identify themselves to you. And this one's really important because, as some of you shared, some people just shut down, some people get really silent, some people bottle things up, and they might not share with you their experiences, right? It's not out of the realm of possibility for someone to just try and put that somewhere else in the back of their mind, and they don't really show that face to the whole world. So don't expect that you're always going to know when someone is experiencing trauma or has experienced trauma. You might not know just off appearance. So just keep that in mind, that you want to make sure that you're applying the trauma-informed approach to all your clients. And you want to allow your clients to switch to a different provider if they don't want to work with you, or if they don't want to work with you without taking it personally. Again, just another one of those things that we want to do in resisting re-traumatization. Hey, when I go to the doctor, sometimes when I'm looking for a new doctor, I sometimes have to look for a new doctor just because I didn't vibe really well with the doctor before. It has nothing to do with that doctor. It's just I'm looking for something different. So trying to keep that in mind. We do that in our day to day as well. We have preferences for friends. We have preferences for family and people that we work with. So we all have our own way of being, and it's okay if someone doesn't want to work with you. Maybe it has something to do with you remind them of someone, or maybe you triggered them in a way, and they need to move on to a different provider. Try not to take it personally. Most of the time I would say it probably has nothing to do with it. It's probably something to do more with what they're going on with something they're going on internal that's going on within themselves internally. Excuse me. Okay. And so last thing we're going to talk about here is, or one of the last few things we're going to talk about here is organizational change. And these are the principles of the trauma-informed approach. And this is whether you're working with individuals or you're working with an organization or institution providing services and interacting with your patients and your clients. So the first one is safety. So throughout the organization, you want staff and the people they serve, whether children or adults, to feel physically and psychologically safe. So the physical setting is safe, and interpersonal interactions promote a sense of safety in this type of environment. And understanding safety as defined by those served is really a high priority for us as well. Trustworthiness and transparency. So decisions are conducted with transparency, with the goal of building and maintaining trust with your clients and your patients and their family members. Third is peer support. So this is peer support and mutual self-help are key vehicles for establishing safety and hope. They're key in building trust and enhancing collaboration, and in utilizing their own lived experiences and their own stories to promote their healing and their recovery. Fourth is collaboration. So collaboration and mutuality importance is really placed on partnering and leveling the power differences between the staff and the client, or the provider and the patient. So making sure that they feel like they're in a symbiotic relationship with us, that it goes both ways. And empowerment and voice and choice. So throughout the organization, and we want to make sure that we're recognizing their strengths and their experiences, and that the organization fosters a belief in the people that they're serving, and in their resilience and in their ability as individuals as well. And the last one we have here is cultural and historical. So the organization works to move past cultural prejudices and leverages the healing value of traditional cultural connections as well. All right, so I'm just going to ask you to do this in the chat box really quickly. I have which of the principles do you believe is most relevant? Oh, you know what? Actually, it's 353. I'm sorry. One second. Oh, well, they got it up and running. That's okay. We'll keep it. So, which of the principles do you believe is most relevant in your work with people you may feel are experiencing trauma? So, go ahead and select the best response that you can. Again, the responses are anonymous, so don't worry too much. I want you to answer as truthfully as possible. So we're at about 12%. So if I can get a few more people to get up there, hopefully we can get up to, let's see what we get in 30 seconds. So we're at 27 seconds right now. And thank you. I see people sharing in the chat box as well. Okay, let's go ahead and close the poll. Thank you, Morgan. So I see that, we have a couple different responses here, but most of you said safety. So most of you said safety. 59% of you, or 17 out of the 29 responses said safety. And then 9 out of 29 of you said trustworthiness and transparency. And then we also had collaboration, neutrality, and empowerment, voice, and choice. But safety, trustworthiness, and transparency, I think, are really important. They're all really important factors, but definitely safety and trustworthiness and transparency. I really think that they're the cornerstone, right? Without those two, we really can't do a lot of the other work. If people don't feel safe, if they don't feel like they're in a trustworthy environment, if they don't feel like they're in a transparent environment, they're not really going to want to work with us. They're not really going to want to share with us, right? So glad to see that. A lot of people choosing safety, trustworthiness, and transparency. So some considerations, organizational considerations for all of you. So how do the agency's written policies and procedures include a focus on trauma and issues of safety and confidentiality? How is transparency and trust among staff and clients promoted? How does the physical environment promote a sense of safety, calming, and de-escalation for clients and staff? So some things to keep in mind, things that you can do. Maybe you can add some plants around the office. Maybe that'll help brighten the mood and maybe let people feel a little bit more calm. Yeah. So some organizational considerations for you all to consider for your workplace. And then trauma exposure. Let's see, we're at 3:55. Morgan, how much more time do I have? I only have like 3 minutes, huh?
You can go all the way up until 5 minutes if everyone's okay with you answering questions via email or
That that's okay with me. If anyone wants to send me questions via email, that's perfectly okay. We'll just have a few more slides here and I'll try to wrap it up as quickly as I can. Um, Okay, so let's talk about trauma exposure, and this is the experience of the provider. So again, I'm gonna skip this poll here. I've witnessed a great deal of trauma in working with my clients. A lot of you, a lot of you answered strongly agree and saying that there was a lot of trauma that you saw showing up in your workplace. So I can assume here that the answer will probably be one, strongly agree. Um, but some different types of trauma exposure. So things that I want to mention really quickly. We have secondary traumatic stress, and this is the emotional duress that results when an individual hears about the firsthand trauma experiences of another. We have compassion fatigue, and this comes from helping others. So you want to keep helping, but you're overwhelmed from being exposed to the trauma of others, and also you have your own life, your own things going on as well. And then this leads to burnout or occupation burnout. And this is a psychological term for that refers to a general exhaustion and a lack of interest or motivation regarding your own work. So it's really important as providers that you recognize these signs and symptoms of secondary traumatic stress here. So hopelessness and helplessness, a sense that you can never do enough, hypervigilance, diminished creativity, fear, anger, and cynicism, numbing, inability to empathize. So just a quick question for all of you, and you can just drop it into the chat box. I think, oh, well, here we go. We have it in the poll. So we'll ask this question here in the poll. And this is in regard to your own experience as providers, with regard to your own experience as providers. How have you experienced secondary traumatic stress? Are you currently experiencing secondary traumatic stress? Have you never experienced it? How would if you would not know how to tell if it was occurring, that's also a response that we have. And I have never experienced secondary traumatic stress. So take a moment to just respond to that respond to that poll. So I'm seeing a lot of you coming up with I see responses all over the place. Some of you, one of you saying that never experienced it. All right, let's go ahead and close the poll now. Thank you, Morgan. So see, I see a few of you saying I've never experienced it. One of you saying I would not know how to tell if STS was occurring. Another two of you said you have not experienced it, but witnessed it in your colleagues. And then most of the rest of you who responded said you've either experienced it or you're currently experiencing secondary traumatic stress. So yeah, incredibly important to be aware of it, to recognize the signs and symptoms. Like I mentioned, this is not an exhaustive list, but these are some of the more common ones: addictions, grandiosity. So being able to recognize that within your own self as well, and knowing when that's happening, is incredibly important. I've experienced burnout myself in the workplace. I had some really terrible reactions. I couldn't hold food down. I was throwing up a lot. And it just wasn't fun. It really derailed my sense of well-being for a good month or so. So recognize these signs when you're experiencing and know when you need to ask for help in your own life as well. Okay. I know you want to take care of other people, but we need to take care of ourselves as well. So I wish we had more time to talk about this, but I'm going to turn it over back to Morgan. And the last thing I'm going to ask all of you is to just drop something in the chat box, one thing that you do for yourself so that you can take care of yourself and restore your sense of well-being. What is one thing that you do for yourself? And if you don't have one thing that you do for yourself, what is one thing that you will do for yourself in the near future? I want you to think of it and try to put it into the chat box. And let us know. And see Michelle saying go to the ocean. That is my place too. So I hear you, Michelle. I go there with my dog and I feel like all my problems go away for those 2 hours. So I would highly recommend that. So I'll turn it over now to Morgan and keep dropping those into the chat box. I'm going to keep reading them. Yeah. Thank you. Thanks everyone.
Thank you so much for joining us. Perfect timing. If you all have any questions, we have Mr. Garcia's contact info for you, and we will be sure to upload this to YouTube and share the link for the video presentation if you want to go back over everything.